Good morning, people. We are really excited to have Dr. Nayan Arora from Portland, Oregon, come all the way to us to present on the art of decongestion. So Nayan is an associate professor of medicine at the OHSU. Previously, he was at UWash in Seattle, and he was recruited to Oregon a couple of years ago, where he co-launched the inpatient cardiorenal service. Where I guess he will talk to us about that. His hobby is on diuretics, of course, in the cardiorenal space. He's also an avid golfer, but he's also on my co-filtrate on the Freely Filtered podcast. So many of you may have heard his voice before. Take it away, man.
Thank you, Swap, and thanks for the invitation. It really is an honor to be here to speak to everybody. So I apologize about the Maple Leafs yesterday. It looked pretty bad. So yeah, the title of my talk is The Art of Decongestion. As Swap mentioned, when I started at the University of Washington, I had the privilege of helping launch and run an inpatient cardiorenal service. And so a lot of the talk today is going to be the things that we thought about and strategies we used in patients where we were consulted primarily for diuretic resistance. Now at Oregon Health and Science University, I run a outpatient clinic, and the management is quite different. And so in this talk, we're primarily focused on inpatients with decompensated heart failure. So before I get started, let's see if I can get this working. Yep, I do have one disclosure. I do consulting work for Novo Nordisk. There's nothing in this talk that represents a conflict of interest because of that relationship. So this was what AI told me is an image of somebody with heart failure and fluid overload. I'm not sure why, but this is what it was. And I think fluid overload has really impacted humans since the dawn of humanity. If you go back to the Iris, this was from Egypt in 1550 BC. There's actually mention of fluid retention and fluid overloaded states with actually proposed treatments at the time. And the term edema comes from the Greek word to swell, and actually the Greek hero Oedipus is named because of swollen feet that were inflicted by his mother to try to prevent a prophecy. So the terms go way back, and many writings of Hippocrates actually mention edema and various therapies. But really, this culminated in the word dropsy, which you guys have probably seen in older literature. This originated from the Greek word for water in the Middle East, the period many years ago, and really came to describe any situation where you had excess fluid in the body, and it preceded our knowledge of sophisticated and distinct disease states. But you can see kind of what various therapies were at the time. So on the top left, you have purgatives, you have leeches, bloodletting, herbal therapies. Asclepius in mythology actually cut the head off of somebody who was fluid overloaded, turned them upside down to drain the fluid, put their head back on, which probably wasn't based in trial data. And then in 1877, Reginald Southey created these Southey tubes, which were these small metal cannulas inserted into subcutaneous tissue to drain excess fluid. And as you might imagine, the big complication there were infections, but they were really used up until the 1960s. I think the way we see treatment of fluid overloaded states and what we would recognize today really started in around 1920 or so. And so this is a fascinating account. If you haven't read it, I highly recommend it. So this is an account by Alfred Vogel when he was a third-year medical student at the Wenckebach Clinic in 1919. And so he was responsible for taking care of a young patient with syphilis and syphilitic heart disease. So his physician he was working with at the time asked him to inject a cc of salicylate of mercury into the patient, and because he had provided incorrect orders to the pharmacy, they weren't able to compound it, so there's a delay in treatment. And it's fascinating the consternation he had as a medical student, feeling like he was going to fail a task that was given to him. And it just so happened that there was an army surgeon who was returned from the war, happened to be on wards that morning. He had received in the mail a sample of nevacerol, which was a new mercurial synthetic agent. And so Alfred Vogel injected that into his patient, and he writes, on the day of the first nevasterol injection, a tall column indicated that the patient's urine output had reached 1,200 cc's as compared to the usual 200 to 500. This evoked my curiosity, but no further comment at the time. Following the second and third injections, however, when she voided 1,400 and 2,000 cc's, I excitedly mentioned it at rounds. My report produced a benevolent smile and rather lengthy but unconvincing discussion of the wave-like rhythm of biologic functions. So essentially dismissed, but when they saw this working in multiple patients, including those without syphilis, mercurial diuretics became quite common. Because of the toxicity associated with it, it spurred interest in synthetic diuretics, and so acetazolamide gets FDA approved in 1953, and that was followed by thiazides, loop diuretics, and mineralocorticoid antagonists in the 50s and mid-60s. So when we think about the bidirectional pathways between the heart and the kidney, of course, all our decongestive therapies are working via the kidney. This is kind of an elegant depiction by Claudio Ronco back in 2008. But over that time, I think we have to modify this a bit. And so, the feeling used to be that all of this was driven by decreased cardiac output, leading to reduced renal blood flow, and that drove the kidney dysfunction. And we know from ESCAPE trials and other trials that that's not necessarily true, although it remains important. And I would argue that the pendulum has swung sometimes too far where it's not considered enough. And I'll talk about that in a minute. He also has this pathway with exogenous factors. I don't want to get into a debate about the nephrotoxic potential of contrast media, but I think we can agree that things like ACE inhibitors, diuretics aren't inherently nephrotoxic. There's also a lot of interest in immune-mediated damage, specifically with endothelial activation. A lot of research going on in this, but as a clinician, because there's nothing we can do about it, when I see the patient in front of me, I can kind of ignore this pathway for now. So really what it comes down to is increased venous pressure, which we know elevated central venous pressure has an inverse relationship with glomerular filtration rate, and then blockade of the renin-angiotensin-aldosterone pathway. But I show you slides later on that's going to suggest that neurohumoral blockade, while obviously vitally important for long-term outcomes, is maybe not as important on the inpatient setting when somebody's acutely decongested. So a lot of our focus goes to increased venous pressure and how do we effectively treat that. So when I talk about the cardiac index and cardiac output not being quite as important, this is an older study from 1990 looking at patients with heart failure and breaking them down into tertiles of cardiac index. So essentially what you can see is as cardiac index declines on that x-axis, you have a linear decline in renal blood flow. Filtration fraction goes up, promoting sodium reabsorption, but GFR is relatively constant across a wide array of cardiac indices. And that's really because of the autoregulatory capacity of the kidney. Really what it's doing is vasoconstricting your efferent arteriole. That whole system breaks down at some point. In this case, it was around a cardiac index of 1.7. We think about this somewhere around a cardiac index of 2. There's a lot of interpatient variability. This is not going to affect the majority of patients admitted to a hospital with decompensated heart failure. Our argument is that most of the institutions I've worked at, really all of them, nephrology is a consult service. We get consulted for cases of diuretic resistance or acute kidney injury. I think this is going on more than we think. And we've caught many patients on the floor that don't have obvious signs of low flow states and will measure a cardiac index and it's low. Anecdotally, this is going to be your younger patients that are able to better compensate. So something that's always running through our mind when we're getting those consults. The other variable that I don't think gets discussed quite enough is renal perfusion pressure. You can measure this relatively non-invasively with a map and a central venous pressure. So I'm borrowing here from the hepatorenal literature. Let's see if I have a pointer. So on the bottom, you can see with decline in renal blood flow, you have a rise in norepinephrine levels. So essentially, your sympathetic nervous system gets activated. And again, this is hepatorenal physiology, but I think a lot of the same principles apply to patients with cardiorenal physiology, where on the right, you have the renal autoregulatory curve. And what happens is when you have a state of sympathetic nervous system activation, that you get this rightward shift in your renal autoregulatory curve. And what happens is that blood flow becomes even more critically dependent on blood pressure. And so this is another thing that we think about because as you guys all know, people want to jump to talk about diuretics and everything, which is the more interesting part of this. But without appropriate flow to the kidney, you're not going to maximize potential of diuretics. So these things are always running through our mind, and we have strategies to impact these variables if they need to be acted on. But what it comes down to mostly is how do we utilize diuretics? We just talked about that loops and mineralocorticoid, all of these were FDA approved in the 1960s. Over the next 60 years, we don't have other tools. And I would argue we still don't really know the best way to utilize the tools that we have. And so this is how we've thought about the data, and then we created a diuretic algorithm, which I'll show you towards the end here in terms of how we kind of go through this process. So not surprising to anybody, I could show you many of these trials. This happens to be the PROTECT trial. But the point here is that if you're discharging patients with residual ongoing congestion, outcomes are worse. And so in the solid line here, these are patients who have been fully decongested. This was based on jugular venous pressure, peripheral edema, and orthopnea in this study. If you have even mild congestion, your outcomes are worse, both in terms of mortality and rehospitalization. If you look at registry data, it'll suggest that only about 15% of patients with heart failure are fully congested at the time of discharge. That suffers a bit from different definitions of decongestion, but either way, it's a minority of patients. Even if you look at trial data, so this is the dose trial. This was looking at bolus dosing versus continuous dosing of loop diuretics, also low dose versus high dose. If you look at the high dose arm and look at the proportion of patients that were free of congestion at 72 hours, it was less than 20%. And this is in a trial setting, let alone, us taking care of patients in the hospital. And so the question is, why are we so bad at this? And I think there's a few reasons. One is that serum creatinine is just a bad biomarker in heart failure, particularly with active decongestion. I'm not going to talk about that today because I think that's been discussed, in many forums. I think in a group of nephrologists, we've all accepted that, small trivial changes in creatinine are not necessarily detrimental. In fact, a lot of studies have shown actually better prognosis in patients where they have a small rise in creatinine with decongestion. But the other factors are traditional metrics may not be accurate that we usually use. And then finally, diuretic resistance is common, and we don't have a lot of defined strategies of how to overcome diuretic resistance. So when we talk about traditional metrics, it's really looking at cumulative fluid balance with intake and output, as well as changes in weight. And so this is an often quoted study by Jeff Destany out of Yale, who's obviously done a lot of work in this field. So he looked at the correlation and agreement between diuretic-induced fluid and weight loss in 3 large trials. So the dose trial, the escape trial, and the PIN cohort. And on the right, you have these bland Altman plots. And if people are familiar with these, essentially what you're seeing is that because of the nature of this, the correlation between those 2 outcomes were very poor. It's not a great study in the sense that it's hard to interpret these, and you can't tell if the discrepancy is based on one variable or the other here. The author's conclusion that it was both. But if you just think, I think practically about what we see in the hospital, I have a very hard time getting accurate intake and outtake data in my non-ICU patients in particular. And though we ask for daily standing weights, many times bed weights are being done, which show a lot of variability day to day. Even if they use different scales, we see different variability. And so it can be hard to trust that the data you're getting is accurate and to act upon that. So one of the things that has gained a lot of traction recently is using a spot urine sodium timed approximately 2 hours after a diuretic dose, particularly a loop diuretic dose, to at least determine a threshold dose of your diuretic. And for whatever reason, this has actually evoked a lot of strong opinions, especially on social media, about the utility of this. I will tell you, we use this a lot. And there were smaller studies that actually showed that if you weren't achieving a threshold dose of urine sodium, your outcomes were worse. And other studies also showed that what was important was achieving net negative sodium balance. So if you achieved net negative sodium balance in a hospitalization, you had better outcomes, irregardless of your cumulative fluid balance or your weight changes during the course of that admission. So that culminated in 2 relatively large trials. This is the PUSH-AHF trial. This was over 300 patients that were randomized to either a natriuresis-guided diuretic therapy or standard of care when they were admitted for decompensated heart failure. What they looked at was 24-hour urine collections and showed better natriuresis in the group that was randomized to the natriuresis-guided diuretic therapy. As with every diuretic trial we have, there was no difference in all-cause mortality or heart failure rehospitalization at 180 days. So there's been no diuretic trial that has actually shown mortality benefit or long-term benefit. And the protocol that they used was this. So what they did was they used this urine sodium less than 70 to define a poor response. And they would increase doses of loop diuretics to a maximum of 5 milligrams of bumetanide. And if patients were still below threshold, they would preferentially add hydrochlorothiazide, followed by either acetazolamide or an SGLT2 inhibitor to achieve that urine sodium threshold. The ENACT trial was the other trial looking at this. This was over 400 patients. Similar methodology. They used a urine sodium greater than 50 to define a threshold response to their diuretic therapy. Similar to PUSH AHF, they would maximize their loop diuretic. In this case, it was a 200 milligram dose of furosemide, and then they would add a thiazide if patients were below threshold. I think this is the outcome that really matters, and they showed a reduction in length of stay with patients that were randomized to the natriuresis-guided protocol, because really what you're doing with this is you're removing clinical inertia. Most of the time, what we see is somebody gets a diuretic, people wait 24 hours, they see the next morning what was their cumulative fluid balance, what was their weight, and then they make changes based on that data. What this is doing is allowing you to get data within 2 hours and adjust your diuretic therapy if you need to. And so if a patient comes in the morning, it's often that we'll make multiple changes over the course of that first hospitalization day in order to achieve decongestion more quickly. A lot of people would argue, well, you can just use urine output, which is absolutely true. If you have an accurate way to collect urine output and you trust that data, we use 150 cc's an hour to define an adequate response. But many times we don't have that data available. It's easier just to get a urine sodium, which is quick, it's cheap, it's easy to get, it goes in the chart, and then you can make changes. There's actually programs that will have created nurse-driven protocols where it's an automatic escalation of therapy if patients aren't at goal. This is not some magic biomarker that's going to tell you if a patient is fully decongested or not. You still have to use your traditional tools, whether that's physical exam, right heart catheterizations. We use a lot of bedside ultrasound in our practice to determine euvolemia, but I think this does help you in certain situations. But the main, I think, issue is that diuretic resistance is quite common. If you look at the literature, it's going to suggest that it's about a 30% prevalence. I think, the problem is diuretic resistance lacks a uniform definition. I tell my fellows it's like a duck. You can know it when you see it. You know when patients aren't responding adequately to loop diuretics. And one of the main causes is adaptation in the nephron, and this is a really nice review by David Ellison that's still relevant, published in 2017, showing that's increased expression of sodium chloride cotransporters in the distal tubule, which cause sodium reabsorption beyond where loop diuretics work and make them less effective. That's been supported by animal models. These are mouse models that are exposed to loop diuretics, and you see this hypertrophy of the distal tubule and increased expression of NCC mRNA. And so this has led to the gold standard of thiazide generally being used preferentially if people are failing loop diuretic therapy, which I agree with, but worth noting that that's not based on robust randomized trial data. In fact, probably the best trial we have of this is the chloride trial. This was published in 2023. It's a Spanish study. They took 230 patients with decompensated heart failure. Like most diuretic trials, this was upfront therapy, meaning patients were randomized at the time of admission to 5 days of either hydrochlorothiazide or placebo. To be eligible for the trial, they had to be on at least 80 milligrams up to 240 milligrams of oral furosemide. That number is going to be important as we try to compare studies. And so we'll go back to that. On the right, you can see hydrochlorothiazide in blue here and placebo in gray. So you had better weight loss and better diuretic efficacy, which was defined as change in weight per 40 milligrams of furosemide over 96 hours if you got hydrochlorothiazide. That came at the expense of more hypokalemia, as you'd probably expect, as well as increases in creatinine, but we already talked about, that may or may not be relevant. So that's the main data. Aside from the CRUST trial, which obviously used metolazone as step pharmacologic therapy, this is the main randomized data we have to support the use of thiazides. When I started doing this, I think one of the things that struck me, especially as I got interested in the use of net negative sodium excretion to define success, is why we didn't focus more on the proximal tubule. We all know that in normal circumstances, we reabsorb, let's say, 65% of our sodium proximally. That goes up to about 80-85% in patients with heart failure. Combination of, increased filtration fraction, which we saw, but also increase in lymph flow, which washes out interstitial proteins, decreases colloid osmotic pressure in the interstitium, basically creating this environment to promote sodium reabsorption proximally. And even though acetazolamide was the first FDA-approved synthetic diuretic, it really lost favor. Part of this was there was randomized trials of acetazolamide versus mercurial diuretics, and no surprise to anyone, acetazolamide lost that battle because loop diuretics mercury is essentially a toxic loop diuretic, which is obviously going to be more effective. But there was obviously the ADBOR trial. So there was a number of smaller studies from the same group in Belgium that culminated in the ADBOR trial in 2022. I know people are familiar with this, but to remind everybody, this was a multi-center randomized trial. So it was 27 sites in Belgium, 519 patients with decompensated heart failure, who had to be on oral maintenance therapy of at least 40 milligrams of furosemide for a month prior to enrollment, but no more than 80. So that's going to be important as we compare studies. Important exclusion criteria were an eGFR less than 20 or use of an SGLT2 inhibitor. This was conceptualized before we knew how important SGLT2 inhibitors were. And they were then randomized to either once a day acetazolamide 500 milligrams intravenously or placebo, with a primary endpoint of successful decongestion with secondary endpoints that looked at longer outcomes. On the right, you have acetazolamide in red here, placebo in blue. And so there was more cumulative diuresis as well as natriuresis in the arm that got acetazolamide. So the difference in mean sodium excretion was 468 millimoles if you got acetazolamide versus 369 millimoles if you got placebo. And so they also showed better decongestion at 3 days, so 42% versus 30% in placebo. We'll talk about this congestion score on the next slide, and more successful decongestion at the time of discharge. So 16% more patients were successfully decongested at the time of discharge. They also showed about 1 day decreased length of stay if you got acetazolamide. So the bottom line of this study was that it was positive. It got a lot of press, I think increased awareness and utility of acetazolamide in practice. But one of the problems was the way they defined decongestion. So this was a novel congestion score that they actually created, which composed of peripheral edema, pleural effusions, and ascites. To be defined as being successfully decongested, you had to have no pleural effusion, no ascites, and no more than trace edema. I think practically, if I think about my patients, I can't remember the last time I had somebody with ascites that I was able to diurese off their ascites within 2 or 3 days with diuretics alone. And so I have a little bit of a problem with how they define that. And this was buried in the supplement, actually. And so we were big fans of acetazolamide even before this. It was part of our diuretic protocol for years before this came out. I'm not convinced that if I wasn't already a fan, that this would have convinced me to change my practice. But we'll show some comparisons in a minute here. The other proximal diuretic are SGLT2 inhibitors, if you want to classify them as diuretics. These are, of course, the only medications that have also shown mortality and morbidity benefit in patients. And there is a physiologic basis for considering these in terms of acute decongestion. We already know that SGLT2 inhibitors should be started on every patient with heart failure. It's safe to do during an acute inpatient hospitalization. The question is, can it help you with acute decongestion? And so when you look at mouse models, so for rats that were infused with angiotensin II, and they're looking at SGLT2 mRNA. And so these are controls. Angiotensin II increased expression of SGLT2. The rest of the study was just looking at the impact of losartan and empagliflozin. But the point here is that angiotensin II is obviously a major player in heart failure. It increases sodium reabsorption indirectly through its impact on the sodium hydrogen antiporter, but could it also be doing that through SGLT2 channels as well? So a few studies have looked at this. This is the MPAG-HF trial. This was a single center trial, randomized patients with acute decompensated heart failure, like every other study, upfront therapy within 12 hours to either 25 milligrams of empagliflozin or placebo. It was 60 patients. All of them were receiving loop diuretics, and their primary endpoint was simply what happens to your urine output over 5 days. And on the right, empagliflozin is in blue, placebo is in red. There was a 25% increase in urine output, greater improvement in BMP, and improved diuretic efficiency, which in this case was defined as milliliters of urine output per milligram of furosemide equivalent. And so all looks good, but then you look at studies that have actually looked at the composition of the urine in these patients. So this is a sub-study of the EMPEROR response trial, which was looking at the efficacy of empagliflozin in acute decompensated heart failure. 79 patients randomized to 10 milligrams of empagliflozin versus placebo. They similarly found a 25% increase in urine output. But on the right here, you're looking at what was actually in the urine in empagliflozin versus placebo. And they found that the primary driver of the increased urine output was glycosuria. So really creating an osmotic diuresis, more of an aquaresis, not a natriuresis, which, if you believe the data that we showed before, may not be achieving the goals that you want them to achieve. And so the pendulum really swung back and forth about how useful these actually are really until this study by Cox and colleagues was published at the end of 2024. So this was a multi-center trial of 240 patients randomized within 24 hours of admission with hypervolemic heart failure to 10 milligrams of dapagliflozin versus placebo. They actually obtained 24-hour urine collections. And in this case, they did show that combined with furosemide, there was increased 24-hour if you got dapagliflozin versus usual care, similarly increased urine output. But at this point, it does seem you are getting a natriuretic response that seems to wane after a few days, but can help you in your patients that are acutely congested. And so it's not generally going to be the difference between a patient needing ultrafiltration or not, but given that we know how important these are anyway, and safe to do so, can help you a bit. But the problem we have is that all of these studies, what they've looked at is they've taken a population of patients with heart failure, randomized them to 1 diuretic versus 2 diuretics, and then looked at outcomes. And I think we can all predict that 2 diuretics are better than 1. That's essentially what they've shown. And that doesn't necessarily help us figure out how to utilize these tools. I don't know if anybody read I love these books, these Choose Your Own Adventure books. This is essentially what's happened for people taking care of these patients, is that they're kind of left to decide on their own how best to use these different tools that we have. And there's no guideline to help us with what is the optimal diuretic strategy in folks. And so, there are a number of studies such as this one showing that if you have higher doses of loop diuretics, these are ambulatory patients, your outcomes are worse, okay? And the logical conclusion to this is that the sicker the patient, they need higher doses of loop diuretics, that's driving these outcomes. As I've done more outpatient work in this field, I've come to realize there's probably something to this where you really want to minimize your doses of loop diuretics in your outpatient. We've been very successful with GDMT, particularly with things like sacubitril, valsartan, and SGLT2 inhibitors to minimize and even remove loop diuretics from patients, because we know that loop diuretics also act on the macula densa to increase renin release, right? They're blocking that signaling in the macula densa. And every study has shown that increased levels of renin and aldosterone lead to worse outcomes, or at least associated with bad outcomes in patients with heart failure. I don't know if that's relevant in inpatients. And so what this study by Mentz and colleagues showed was they looked at the dose trial and the CREST trial. And they looked at patients that had plasma renin activity and aldosterone measured. So on the left is your PRA. Within the trials, they're looking at bolus dosing of diuretics, continuous dosing, low dose, high dose, pharmacologic therapy versus ultrafiltration. In all of these groups, your plasma renin activity increased. It was most for the ultrafiltration arm, higher for continuous infusion, but basically went up in all groups if you were getting loop diuretics. There was really no significant change in aldosterone. But what's important is that those changes in PRA and the folks that did have changes in aldosterone, it didn't lead to worse 60-day outcomes. And so whether that's because renin and aldosterone don't matter in the acute setting versus these transient changes aren't important. I don't know, but it was reassuring that, using high dose of loop diuretics in patients who are clearly volume overload doesn't seem to be harmful on the inpatient side. And we have very few diuretic comparison trials. This happens to be one of them. So looking at metolazone versus dapagliflozin in patients that were hospitalized with heart failure and diuretic resistance. So this is one of the few trials that actually looked at diuretic resistance. The way that was defined in these 61 patients was a decrease in weight by less than 1 kilo or cumulative fluid balance less than 1 liter over the preceding 24 hours, despite at least 160 milligrams of furosemide. And so it is a population that we would consider, failing loop diuretic therapy. They were then randomized to 10 milligrams of dapagliflozin or metolazone. And on the right here, so what you're seeing is dapagliflozin in blue, metolazone in this gray color. And there was no change in weight between the two groups, no change in the ADVOR congestion score, whatever we want to think about that. There was more hypokalemia and a higher creatinine if you got metolazone versus dapagliflozin. So it kind of seems like a win for dapagliflozin. But when you look at the actual data, the patients that were on metolazone needed significantly lower doses of loop diuretic to achieve the same response. So it still seems that thiazides are going to be, more powerful than SGLT2 inhibitors to achieve these results. The other one, this is a really nice study. This is the DEA heart failure trial. A small study. It was 42 patients, and these were ambulatory patients that were randomized to one of 3 diuretic regimens, and it was a crossover trial. So each one got weekly treatments with either IV furosemide plus metolazone, furosemide alone, and furosemide plus acetazolamide. Furosemide was given at 250 milligrams, so it was a 40 milligram bolus, followed by 50 milligrams an hour for 4 hours. And then they looked at various results. So I'm going to blow that up for you. And on the left, you have furosemide versus metolazone in each graph. The middle is furosemide alone, and on the right is furosemide plus acetazolamide. And they looked at things like natriuresis, urine volume, and weight difference. Interestingly, only furosemide plus metolazone improved those parameters, whereas the addition of acetazolamide in these patients, ambulatory patients, so may not be relevant to inpatients, was no better than furosemide alone. The other way to potentially compare these is to look at those trials and say, well, what was the urine output in the intervention group versus placebo? So in the ADVOR trial, acetazolamide increased urine output compared to placebo by about 12.5%. In empagliflozin, it was 25%. In the chloride trial, it was about 27% or so. And then if you look at, well, what was their baseline furosemide use? It was 40 milligrams in ADVOR versus 80 in chloride. So not only did the thiazide give you more urine output compared to placebo, these patients were more exposed to loop diuretics, making them a more, quote unquote, diuretic resistant population. I didn't include empagliflozin because this study was primarily de novo heart failure. So a minority of patients were on loop diuretics prior to the trial. What about total urine output over 48 hours in these studies? So ADVOR was about 4.5 liters at 48 hours. MPAG-HF was, just under 4 liters. And then CARES was 6 liters. With step pharmacologic therapy with loop diuretics and metolazone, when you look at PUSH-AHF and ENACT, 20% of those patients needed adjunctive therapy on top of loop diuretic to achieve, that threshold response. And this was primarily with thiazides. And similarly, they found 6 liters of urine output over 48 hours. So it's possible that there's something about 6 liters in 48 hours that is, maybe should be our target. And same thing, baseline furosemide in CARES was 80 milligrams, so double that of the ADVOR population. So this is how we synthesized this data and came up with a diuretic protocol. So I'll be curious how people do things here. The top is really analogous to the CARES trial. So we had escalating doses of loop diuretic with the addition of generally metolazone in our institution as the thiazide of choice. The way we assessed success was we did use a lot of spot urine sodiums. This was a compromise standardized amongst a few different people that were involved in putting this together. So we just gave a range of 50 to 80. And then we had parameters to increase or potentially decrease therapy depending on changes. We would tolerate, up to a 50% rise in creatinine if decongestion was appropriate. But realistically, we were involved in the vast majority of these cases if creatinines were going up significantly during therapy. The bottom of this protocol had this, flow for proposed adjunctive therapies. It's very telling that we had to put this, no evidence for low-dose dopamine because this was still used a fair amount. And so first line again was thiazide diuretics, but then we had choices for second line therapy, and so it really depended on the characteristics of the patient. If you were hyponatremic, if you were hyperkalemic, particularly if you had low chloride, and really that's going to be high bicarbonate, we would use acetazolamide. Sub-analyses of the ADVOR trial showed that acetazolamide was particularly effective if you had a serum bicarbonate greater than 27. And we used a lot of hypertonic saline in our practice as well. If you had low potassium, we would use preferentially amiloride, actually, because of the rapidity of action. Spironolactone can be used, it just is slower. And there was a study by Shweta Bansal suggesting that to actually achieve natriuresis, you needed 100 to 200 milligrams a day, which is very different from the guideline-directed medical therapy doses that are used. And then we had SGLT2 inhibitors here on the right, suggesting 25 milligrams. We had empagliflozin on formulary, so we would preferentially use that. Maybe we're going to need to move this up higher, depending on, as more data comes out. But that's how we would kind of, think about utilizing these other agents. And this was posted in our CCU for the practitioners there to reference if they needed. The point, though, is that if you're going to do this, decongestion is important, but it has to be paired with a plan for appropriate long-term medical therapy. There's a reason these studies have not shown improvement in mortality and heart failure rehospitalization, because you need that medical therapy. And then the way we do this is all of these patients, particularly if they have acute kidney injury or chronic kidney disease, they see us in our cardiorenal clinic, and we very rapidly titrate. We call it guideline-directed medical therapy, but it's actually just medical therapy because we do this regardless of your GFR. We do this in dialysis patients in order to recover EF, and so we have a very strong program and a protocol to very rapidly initiate and continue these medications. Because when you look at, so in red here is enhanced decongestion, and what that means is studies looking at a loop diuretic plus an adjunctive agent versus GDMT in green. Early in an admission, you're going to make patients feel better, right? They come to the hospital because of that venous congestion leading to symptoms. You're going to make them feel better pretty quickly, but that plateaus after that. You're not getting more benefit to an extent, and you really need that other medical therapy to not only improve symptoms, but improve functional status for these patients. And I think that's one of the reasons that ADVOR has that paradox that we've seen with many trials, that they improve decongestion based on their definition, but they didn't show improved outcomes. And if you look at the use of GDMT in that group, high uses of beta blockers, remember SGLT2 inhibitors were excluded from this, so are not included here. Only about 50% were on an ACE, ARB, or ARNI, which really only went up to about 58% at the time of discharge. Similarly, a minority were using mineralocorticoid receptor antagonists that did increase a bit, but without that long-term therapy, you're really not gonna, do much for these patients long-term. And so in the last few minutes, because hypertonic saline was discussed at Kidney Week this year and actually generated a lot of comment, we do use this a lot, so I did want to spend just a few slides on this. And so I'm going to focus on the original Italian studies, which really are our main randomized trials here. So the initial one was in 2000. This was a single center trial of 60 patients, refractory heart failure. I'll show you that definition in a bit, that were randomized, again, upfront therapy to either furosemide alone at pretty big doses, 500 milligrams to a gram, with or without hypertonic saline. It was 150 cc's given twice a day at varying concentrations based on the serum sodium. And what you're looking at here is the furosemide without hypertonic saline on the left, furosemide with hypertonic saline on the right. They showed improvement in weight loss, about 500 cc's more urine output, and better BUN and creatinine if you got hypertonic saline. This was followed up by the largest randomized trial we have, but same single center. It was in 2011 called the SMAC heart failure trial, over 1,900 patients, very similar methodology, except now they randomize people who got hypertonic saline to a quote unquote moderate sodium diet at the time of discharge, which was about 2.7 grams of sodium a day, versus low sodium diet. If you got furosemide alone, that was about 1.8 grams of sodium a day. This was the criteria. So adult patients with low ejection fraction, unresponsive to this, cocktail of things for at least 4 weeks. If you had a serum creatinine greater than 2.5 or BUN greater than 60, you were excluded from the trial. And very similar here, but now you're looking at furosemide with hypertonic saline on the left, furosemide alone on the right. Similar findings, reduction in weight by about 3 kilograms, 500 more cc's diuresis, better BUN and creatinine if you got hypertonic saline. They decreased length of stay by about 2 days and unbelievably showed these incredible Kaplan-Meier curves of mortality and hospital readmission over almost, like a 6-year follow-up, which I do not believe these results, to be honest with you. I don't think you can, show this significant, mortality benefit with that intervention alone. There's only been one other trial looking at mortality with hypertonic saline administration. It was a Chinese study, also single center. They looked at hypertonic saline combined with a very restrictive fluid intake of 500 cc's a day. Only other study to show any kind of mortality benefit, but we're limited to these single center trials. So again, I don't believe this data, but I will say that we've used a lot of hypertonic saline successfully for acute decongestion. But the problem is this. So the reason I showed the Italian studies is they collected 24-hour urine collection that looked at sodium excretion. So I'm going to summarize all this for you in a couple slides, but this is just to show that you did have more sodium excretion if you got hypertonic saline versus furosemide alone, both in that initial 2000 study as well as the SMAC heart failure study. So I'm going to summarize those numbers here. So in the initial study, you had 198 versus 129 millimoles of sodium, 119 versus 76. So the difference is 69 millimoles versus 43 millimoles. So that looks good until you remember that they're getting 150 cc's of hypertonic saline twice a day. Regardless of the composition of saline, if I'm giving this twice a day, these patients are coming out net sodium positive at the end of these 48 hours, right? And so if you believe all this sodium excretion data, this is paradoxical to how we would think about treating folks, right? So how can you explain, some of the success that other trials, studies have at least suggested in this field? And it made me realize, maybe not just me, many people have thought about this. Maybe it's not the sodium, maybe it's the chloride that is driving that benefit. There's a lot of literature suggesting that hypochloremia is associated with bad long-term outcomes in patients with heart failure. But because this is more of a diuretic talk, I just want to focus on the diuretic resistance component. So this is a study by Dr. Handberg and colleagues out of Yale. And what they looked at was, what is your diuretic efficiency? And this was defined as sodium excretion per doubling of loop diuretic dose across a range of chloride. And so basically they found this U-shaped curve where both hyperchloremia and hypochloremia was associated with reduced diuretic efficiency, hypochloremia being worse than hyperchloremia. When they did a multivariable analysis, chloride remained an independent predictor of hyporesponsiveness to diuretics, even when you controlled for things like serum sodium, serum bicarbonate, and other factors. And there is kind of physiologic basis for this. So if you look at basic science data, what you're looking at here is in vitro studies with oocytes were injected with NCC and WNC4, NCC and WNC4 plus WNC1. Bottom line was there was no change in the glycosylated NCC, but we needed immunohistochemistry and you stained for NCC, surface expression of NCC. You saw that WNC4 suppressed NCC activity by about 85%. WNC1 tended to prevent that inhibition, but in my discussions with David Allison on this, it seems that WNC1 is not a major factor within the kidney, so it's really just WNC4 that seems to be controlling NCC expression. And when you look at mice with WNC4 missense mutations, they display hypertrophy of the distal convoluted tubule, which is very similar to what we saw in the animal models that were exposed to loop diuretics, right? And so the simplistic view here is that WNC4 seems to inhibit NCC activity. And the reason this is relevant to chloride, it appears that Wink4 is a chloride sensor. So if you look at studies with knock-in mice that have chloride insensitive mutant Wink4, so unresponsive to chloride, these mice phenotypically essentially have Gordon syndrome. So they're hypertensive, they're hyperkalemic, and they have these hyperactive NCC channels. And when you give potassium chloride, it doesn't change the total number of NCC channels, but change the number of phosphorylated NCC channels only in the wild type mice, not in the mice that had the chloride insensitive mutant Wink4. And it appears that Wink4 acts as a chloride sensor to regulate NCC activity. And if you move on, the bench, back to the bedside, that same Hamburg study, so this was a study of I think 140 patients at the Yale Transitional Center. And so they looked at patients with hypervolemia that were given loop diuretics and looked at the response in the patients that were hypochloremic versus normal chloremic. And what they found was that in the hypochloremic population, there was no difference in the quantity of diuretic excreted, so it's reaching its site of action. There was there was a decrease in diuretic efficiency, which we saw previously, and no difference in the fractional accretion of lithium, suggesting that the issue is beyond the proximal tubule. So it can't pinpoint where in the nephron this is taking place, but at least is supporting the prior hypothesis. And when you look at a post hoc analysis, the SALT-HF trial, so SALT-HF was a study of hypertonic saline in ambulatory patients with volume overload. They looked at the response of hypertonic saline in patients that were hypochloremic. And so similar to the prior study, they showed that if you were hypochloremic, this is furosemide alone, you were hyporesponsive in terms of 3-hour urinary sodium excretion. Hypertonic saline appeared to attenuate that response in patients that were hypochloremic. And when they looked at the dichotomy of response to hypochloremia or not at a transition point of 96 millimoles per liter, that seemed to be the transition point where if you had a chloride above that, you didn't see that differential response versus if you had a chloride below 96, you did see that change. So maybe that helps guide, how to utilize some of these things. Obviously, whether chloride is a target or just, kind of an innocent bystander, we don't know. Jeff Testani and others are doing studies on lysine chloride to see if it's a potential therapeutic target, but we won't have that data, I think, for a few years. So in conclusion, after doing this for a while, I've come to the conclusion that it's probably the destination, not the journey. I don't think it really matters how you decongest patients as long as you're doing it. So, maybe that choose your own adventure was correct. You can kind of use whatever tools you have. Maybe there's something to the 6 liters in 48 hours, but again, that's just supposition based on what's been done in other studies. Obviously, decongestion has to be paired with long-term medical therapy to have sustained success. I had this period where I thought that maybe balanced diuresis was better than maximizing loop diuretics first. I still think there's some value to that if you want to avoid some of the electrolyte abnormalities that you would see. But again, if you're actively paying attention and repleting electrolytes, again, it probably doesn't matter how you're approaching this. It'd be nice to know if there was a synergistic effect of SGLT2 inhibitors and acetazolamide. I think there probably is. They're acting on different places, but we don't have that data. And it'd be nice to get prospective studies in patients with diuretic resistance. We don't have a lot of studies. Most of it was upfront therapy. So I'm going to end there, and I might have gone a little over, but I'd be happy to take questions.
Awesome. Thank you. So if there are questions, there are some in the chat that we hadn't got to. So if there are questions, please raise your hand and ask them. Let me stop sharing. Oh, there are. Manish, do you want to go first?
Very, very nice talk. I'll spare you the visual. I'm on my bike. That was really excellent. The question I have, and it's something I noticed maybe 10 plus years ago, and I'm wondering if it's improved, which is baseline creatinine measures in these trials. So many of them use serum creatinine and presentation, which we know is going to be an intermix of AKI and CKD. I would render studies that don't do a nephrological baseline, I would almost say they're uninterpretable when you have those two populations mixed. I'm just curious if the literature's improved. Is there something for maybe us to teach our cardiac colleagues about that?
Yeah, no, you're absolutely right. It is basically uninterpretable because of the reason you're mentioning, and the literature unfortunately hasn't improved in that, and you're still looking at, creatinines, at presentation. And so, we had a good relationship with our cardiologist, but it took a while to convince them to, I don't want to say ignore creatinine, but really put much less weight on it. The way we approached it was, if it was cardiorenal syndrome, we weren't, using creatinine for that much. Now there are patients, again, with low flow states, they're not getting appropriate blood flow where you're seeing this rising creatinine with congestion. You have to look for that. The other thing, obviously, we're looking for is, could something else be going on? Do they have tubular injury? Do they have interstitial nephritis? Are there other factors involved? But you're absolutely right. It's a poor biomarker in general, and even more poor in the trials because of how they were ascertained.
Thank you. Greg?
Yeah, kind of a similar question. So at your hospital with your diuretic protocol, are you using that? Is that kind of widespread on the floors in general medicine patients, cardiology units, or restricted to the units?
No, so so the idea was it for it to be widespread. At the time that I left, which was just, last year, the plan was to present this more to the general medicine wards as well, so that they could utilize that if needed. At the time that I was there, was mostly utilized on the cardiology floors. That's, pretty much all the heart failure patients were admitted to cardiology services. So this was used both on the cardiology floors as well as the intensive care unit. And initially, when we started it, it was essentially our service that was driving these things. And then over time, as the cardiologist, we had a very small team. It was just two of us when we started. And so we were doing the same things over and over. So that kind of rubbed off on the cardiologist. They started to see that, mostly run by APPs. And then they would kind of use this independently, and we would actually get called less on this unless they were failing all that therapy on those protocols.
And sort of a follow-up to what Manish just answered. So in practice, so are you using this on sort of widespread GFRs, like across the range, not just sort of?
Yeah, we are. The one exception is hypertonic saline, not necessarily a GFR cutoff, but if they have tubular injury or other factors driving their kidney injury, then we tend to not use it. And we pretty much were restricting that to patients with quote unquote pure cardiorenal syndrome.
And in those patients, sorry, last question, you are using hypertonic saline for most of them?
I wouldn't know, not most. The way we generally use it, where if you were failing, let's say loop diuretics, thiazide diuretics, acetazolamide, plus or minus an SGLT2 inhibitor, then we would, that was our practice to generally use it. So that's different than how they used it in the studies. We were mostly using it as a last resort to stave off ultrafiltration.
I gotcha. Okay, thank you.
Mark?
I really enjoyed that talk. Thank you very much. I'm interested to know what's happened in terms of use of ultrafiltration. So on the one hand, it kind of seems that if you're using the spot urine sodium and you're seeing that patient multiple times in the first day, and you're escalating really quickly, maybe you need less. So has that happened? But at the same time, you're also saying that the most important thing is to get these people decongested as quickly as possible. So, like, where in that protocol does everyone know when to fold their cards and just put the person on ultrafiltration?
Yeah. So there's no easy answer to that. There's no studies looking at, well, let's use all of these things before we resort to ultrafiltration. Again, like suffering from the other trials, most of the ultrafiltration trials were a patient hits the door and they get randomized to diuretics versus ultrafiltration. We would reserve it for, hey, you failed all of those things. In the absence of other reasons for dialysis, that's how we reserve it. We have internal data from UW showing that we reduce the rate of dialysis in these patients. Again, that's internal single center data, but utilizing, and I don't know that it was the diuretic protocol. I think it was the fact that we literally had two people that were seeing all these patients that practiced very similarly. The communication was great with the cardiologist. And so I think it was a variety of factors that led to that, but we did use less dialysis because of this. And again, that's where I think urine sodiums potentially help you, is that you can make multiple changes within a day. And that's what we tell the cardiologist, like, hey, get a urine sodium, let's do all this within the next 8 hours. And if they're failing, we'll dialyze them. And I think that also gave them reassurance that we're paying attention and that we're not, quote unquote, withholding dialysis, but we're doing it appropriately.
And how much of that is like early, I guess, a culture of early engagement of nephrology. So you're not,
A lot of it, yeah, because I will tell you at my current institution, we don't have that because there's no inpatient service. And generally we don't get called by cardiology until like, hey, this person needs dialysis. And at that point, it's almost too late, right? And so that is a problem. So I think early engagement is the number one factor here.
Oh, a lot of questions. Maybe Brendan and then Yolanda said.
Yeah, I really enjoyed the talk as well. And one thing that kind of kept coming up, but you didn't fully explore it, is the concept of free water clearance and decongestion.
Yeah.
Because there's no question that there's a link there. I mean, we've known forever that hyponatremia is a very, very bad prognostic marker.
Yeah.
We know that SGLT2 inhibitors are great at free water clearance, and that might be part of it. And even, there's a hint that the hypertonic saline, that's correcting hyponatremia and actually increasing your urinary water excretion. And so should we be focusing a little bit more on that? Because I know that with the urine sodiums, it is very sodium centric. And of course, while we think of water as being an intracellular, mostly associated with intracellular volume, we often forget that your blood volume is 40% intracellular. And that increasing pre-water clearance, there's good rationale why it should help decongestion.
Yeah, and so there's a lot of strong opinions on this also, and people kind of have two different camps on this. So, the people that believe that we should be focusing more on free water clearance versus not. Obviously, Everest, looked at tolvaptan, et cetera, and the criticism of that was, well, it didn't change long-term outcomes, but none of these studies have shown long-term outcomes, and so how much of a role? I don't know. Basically what we know from all these studies is that urine sodiums are associated with better prognosis, whether that's, because maybe you're not diluting your urine, whatever that may be, that's the data we have. So we don't, in our practice, focus as much on free water clearance. Maybe we should. Again, that Chinese study, when they gave hypertonic saline, that's what they were focusing on because they restricted patients to less than 500 cc's of water a day. The time that we really focus on serum sodiums is if a patient is about to go in for a heart transplant, and then we'll kind of bring their sodium up so that in preparation for surgery. But otherwise, that's been our practice, not to focus as much, whether right or wrong. I don't know if that's the right thing to do.
Yolanda?
Yeah, I'm curious about the outpatient clinic. Do you have this nice kind of stepwise algorithm for inpatient care? And we often stabilize people as an outpatient, but then they destabilize. So do you have a similar sort of algorithm, or how do you monitor? We have these cardiology clinics where patients call in and they get advice from the nurse, and I find that never works. They bring them in, they give them crazy things. Do you have something that kind of keeps people stable, prevents that readmission?
Right. So our focus is on getting them on GDMT in the hospital, seeing them we have the resources to see them very quickly in our outpatient clinic, and there's a whole team involved. And I can show you our outpatient protocol, maybe a little later. I brought it with me, where we have a nurse or a pharmacist that calls every patient the day before we see them and has already done all the prior auths, tells us, what the patient can get. And we institute that, very quickly and rapidly titrate that up with every 2-week visits. And I think that is the main thing that stabilizes these folks. And so, with ARNIs in particular and SGLT2 inhibitors, we found that we can keep people decongested, much better in the outpatient setting. Obviously, we'll use diuretics as needed, and we don't have a protocol for that. It's usually diuretic plus or minus a thiazide. We also have sub-Q furosemide we can use for patients if we really have to. We also use a lot of pulmonary artery monitors like CardioMEMS or Cordellas. We have a lot of patients that live quite far away, and we found that can be very helpful in terms of keeping people out of the hospital.
And then do the patients have some kind of protocol they can adjust on their own, or are they contacting you for changes?
So they, we do give them kind of a weight, saying, hey, if your weight went up by 3 pounds, add an extra, whether that's a loop diuretic, take your thiazide. But they contact us a lot, and we have a very good nurse who fields all those calls and can address things, and then reach out to us in cases that they need to. Without that infrastructure, we wouldn't be able to do any of this. Okay.
That was a great talk. Thank you. Couple questions. So you mentioned you're doing a lot of point of care ultrasound to establish decongestion.
Yeah.
How helpful do you find that? And like specifically, are there things that you're
Yeah, so we personally find it very helpful. So we all generally, and part of this is training our fellows also, will do it on every patient that we see up front. We do utilize, this kind of VEXA score, which you might have heard of, the venous excess ultrasound score. So we're looking at IVCs, we're looking at hepatic veins, renal veins, and portal veins. And then we actually try to do that, maybe not every day, but every other day maybe, and until we, see improvement in that. We did a small study where at UW, where we correlated this with right heart caths and actually found it to be pretty useful. I think what it comes down to is that we know that exam is great, but people aren't necessarily that good at it all the time. And it can be hard to see, jugular venous pulsations in certain patients, relying on things like edema, and others, may not be that effective. And so for us, it's just something that's maybe more objective. And if I think you're trained at it, it can be a useful tool. If you're not trained at it, it's a terrible tool because you don't know what you're interpreting. And so this has allowed us something to maybe it's just making us feel more comfortable that we're effectively decongesting people.
Thanks. The other question is, obviously peripheral ultrafiltration.
Yeah.
Like the negative trials.
Yeah.
Were done, but
Yeah.
like some could say, the trials were not perfect.
Right.
In the sense they were kind of like set it and forget it.
Yeah.
Ultrafiltration.
Yeah.
Do you think the door is completely closed on that?
No, and I think our cardiologists would love it if they didn't have to contact
I
us.
heard that from
Yeah. So, and so I hope that doesn't happen, because I frankly think we do a better job at this than they do, and I'd like to keep control over that. I don't think the doors,
Tell them it's dialysis.
right, exactly. Just tell them that, it depends where the money is in this,
We
right?
did that here 15 years ago. We had a
Peripheral machine, yeah.
yeah, well, Lisa wanted to get one, and we told her that was a bad idea.
Because, they're not seeing the patients afterwards, right? I think we all know that there's harm to dialysis, right? And if they're not going to be seeing the patient in clinics or I don't think they should have control over a technology that they're not then following that patient.
I know those trials the early trials are complete BS.
Yeah.
Like the diuretic resistance.
That's right.
You tried 40, you froze my.
That's right.
Or flat.
Yeah, exactly. Yeah.
Yeah, last question, maybe.
Yeah, I have about 5, but.
I was surprised you had raised your hand.
A Milleride or other case-bearing diuretics seem to be very much an afterthought.
Yeah.
In your algorithm, and cardiologists are always causing hypokalemia and giving a case supplement, which strikes me as insane.
Yeah.
I wish it was.
We use it.
earlier.
We do use it more, and it is kind of your second line in that.
I sort of look for, I hope the potassium is below about 4.8,
Yeah.
so I can add it now.
Right,
I don't
right.
wait till the potassium is low.
Yeah.
Tell me, what do you do if somebody's already on baseline spironolactone before they come in? Is that continued?
It's continued, yeah, and
But not escalated to the diet.
if we
diuretic
potentially
resistance.
need to, we will. Again, I haven't found that much success in terms of, hey, I'm really struggling to diurese this patient, and then increasing the spironolactone is the thing that makes the big difference.
Sure.
I think that's where we certainly continue it.
Milleride's way better in
Correct.
stable patients.
Right.
And of course, I have about 5 questions about hypertonic saline, because
Sure.
that's real.
Yeah, it's an Italian trial and you still showed that.
So
I know.
Italian trial, the early trials had no rationale for why it should work. And then, they give, a few doses over a few days in
Yeah.
hospital, and it improves mortality in 6 months. Like,
I don't believe any of the
like,
mortality.
what's that? Because, I like the rationale that it alters wink response to to low plasma chloride, but surely your plasma chloride only goes up transiently after your hypertonic saline. I haven't the faintest idea how long it stays up
That's
before
right.
it goes back down.
Yeah.
And once it's back down, wink's got a change and
Right.
any effects, it's gonna be very transient.
And all of this is also, is it intracellular signaling? Is it, the serum chloride? I mean, there's so many questions about this.
But you think that when you give it, you see more diuresis and a more.
I'm very confident we do, because we have used this, I don't know, last I checked, maybe 50 some odd, patients, and we have avoided dialysis in a number of those, I think. I can't say for sure. It's not randomized, it's not a trial, this is all anecdotal, but we have patients on everything else you saw on the protocol. That's the only intervention, and people diurese.
I mean, I really like that you add all those things, because cardiologists consult, need dialysis when they're on 80 of furosemide, maybe one other drug, and
Yeah.
like how about piling on with
Yeah.
multiple diuretics?
And I think they know that, hey, if we're reaching, at least in our practice, we're reaching for hypertonic saline, the dialysis line is the next step, right? And so I think the biggest thing is the study showed no harm in using it. And so, hey, if this is a last gasp effort, and there's no harm in it, and it's a cheap intervention, might as well try it.
Excellent. So on that hypertonic saline note, thanks everyone for joining in. And for the fellows in the audience, there will be another talk by Nayan in the afternoon, a chalk talk on diuretics in the outpatient setting, but the staff nephrologists are also welcome to join this afternoon. Thank you.
So throw away in there about using GDMT in dialysis patients.